Hello and welcome to the first podcast in a new series of podcasts, basically introducing concepts in anesthesia. I'm very pleased today to be joined by Shireen. Welcome.
Hello, thank you.
Who's going to be talking us through, in this podcast, some of the most common drugs that are used in anesthesia. So over to you, Shireen.
Thank you. Okay, so today we're going to be talking about the drugs that we'd use preoperatively, intraoperatively, and postoperatively. Okay, so first of all, we're going to talk about the induction of anesthesia and what goes on in the anesthetic room. So when a patient comes into the anesthetic room, there's typically an anaesthetist in there and an ODA or an operating department assistant. It's very important for us to have a blood pressure cuff on, ECG leads and oxygen saturations, as many of the anesthetic agents used can affect the cardiovascular system. So we typically put a cannula in the back of the patient's hand, pre-oxygenate them, and then we can give them the induction drugs. The most common drug used to induce anesthesia is propofol. Propofol is a non-barbiturate agent, which no one really knows how it works, but it does give you a very smooth and rapid induction. It's commonly used with an opiate such as fentanyl, which will increase the sedative effect and also provide some analgesia. The major side effect with propofol is that it can reduce vascular tone, thereby reducing systemic vascular resistance and central venous pressures, and can therefore affect cardiac output and blood pressure. So as I said, it's very important for us to monitor a patient's blood pressure having given them propofol. It's typically metabolized by the liver, but is also thought to be taken up by fat tissue and muscles. One thing to note in terms of patient comfort is propofol stings very much as it goes up the patient's arm. So the best way to avoid this is to pick a big vein to give the propofol in, and to also inject maybe a couple of mils of lidocaine into the syringe to prevent the stinging. Another drug which can be used for the induction of anesthesia is thiopentone. This is a classic drug used in rapid sequence inductions. Now, rapid sequence inductions are beyond the scope of this lecture, but I will be covering it in a future lecture. This drug is a short-acting barbiturate, which again, it's broken down by being redistributed into fat tissue and muscles. It's thought to be quite a dirty drug, causing post-op nausea and somnolence, and hence it's not really used and has been replaced by propofol. Sevoflurane is an anesthetic vapor, so this is commonly used in pediatric anesthesia where it may be difficult to find a vein or to calm a crying child down to be able to cannulate them. So it's a lot easier just to give them some sevoflurane gas to induce anesthesia. Okay, so now we're going to move on to muscle paralysis. So basically, just quickly covering the background of the neuromuscular junction. Okay, so basically when an impulse arrives at the neuromuscular junction, this causes acetylcholine release from the presynaptic terminal. It crosses over and binds to the nicotinic receptors on the postsynaptic junction. This is an ion-gated channel which causes the influx of sodium and further depolarization of the cell. So this is what usually happens in a neuromuscular junction. So we can use drugs which can affect these. So coming here, there are the depolarizing and the non-depolarizing muscle relaxants. So the most common depolarizing muscle relaxant is succinylcholine. This is again used in this concept of rapid sequence induction. It's a very, very fast acting muscle relaxant. Within 30 seconds it works, and it's usually cleared within 7 minutes. The way that this drug works is it binds to the postsynaptic receptor where acetylcholine usually binds, and it causes depolarization of the cell. However, unlike acetylcholine, it's not broken down by acetylcholine esterase, so it stays there for a while longer, keeping the cell depolarized. So even if acetylcholine does try and come and bind and depolarize the cell, it cannot depolarize an already depolarized cell. So this basically hangs around for about 7 minutes until it's broken down by pseudocholinesterase. There are a certain group of people in the population who are pseudocholinesterase deficient, and it takes them a little while longer to break down the succinylmethonium. So these patients, you have to take the utmost care if you do decide to give them succinylmethonium. Much more commonly, the non-depolarizing muscle relaxants are used, and these competitively bind to the acetylcholine receptors and block acetylcholine from binding there. So these are vecuronium, rocuronium, and atracurium. Clinically, I've seen all three of them being used, and they all do tend to have the same effect. Just one thing to point out about atracurium is that it can cause some bronchospasm, so you'd avoid it in a patient who's asthmatic. It also, a good thing about atracurium, however, is that it's broken down largely within the blood. So if you have a patient with liver or renal impairment, then it probably would be the drug of choice. Okay, moving on. So now we're going to talk a little bit about maintenance of anesthesia and the drugs we would use. So to maintain anesthesia, we can use gases such as desflurane, isoflurane, and sevoflurane, or we can set up a propofol infusion. It's commonly called a TIVA, which means a total intravascular anesthesia. So talking a bit about the gases, deciding which one to use can be quite controversial. Each one has its own advantages and disadvantages. So for example, with desflurane, it's quite an irritant to the respiratory system. So you wouldn't use it in a chronic smoker or an asthmatic. But on the upside, there is an increased recovery, and the patients do recover from it quite quickly. Isoflurane, is the advantage of that is it's a very, very cheap drug to use. However, it does take quite a while to wake the patients up after they've been given that. And sevoflurane is probably the best of the three, but the main problem with this is it's a very expensive drug. Now, if you see next to each drug, there's a MAC and a number. So MAC stands for the minimum alveolar concentration. And what this means is the minimum concentration of the vapor required in the lungs to keep 50% of men at sea level anaesthetized and not responsive to a painful stimulus. This is demonstrated as a number, so you would always try to keep the MAC of a patient as being 1. If it's more than 1, then maybe it means that they're too deeply anaesthetized. If it's less than 1, then they're probably quite light. When you're giving a patient the propofol infusion, there's no way of determining how deep or light they are using a MAC, because obviously you're not giving them a gas. So what I've seen many anaesthetists do is use something called BIS monitoring, which stands for bispectral index. And what this is you stick EEG monitoring on the patient's forehead. This computer analyzes the EEG and gives you a number anywhere between 0 and 100. So in a normal aware person, the monitor would show 100. In an anaesthetized person, you want to keep the number between 40 and 60. If it's above 60, they're probably a little bit light. If it's below 40, you're using too much propofol. You don't need to use that much. So it's usually between 40 and 60 that we would use. So that's how the drugs we use to maintain anesthesia. Moving on to the emergency drugs now. So intraoperatively, anaesthetists, we tend to tweak the blood pressure and the heart rate to keep everything within a kind of acceptable range. However, at some points there are sudden drops or rises in blood pressure and heart rate. So now I'm going to talk about some of the drugs that we can use to combat these. Fine. So if a patient has dropped their heart rate, but you're quite happy with the blood pressure, you can give an anticholinergic such as atropine, or glycopyrrolate. If a patient has dropped the blood pressure, but but the heart rate is okay, then you'd give an alpha agonist, which would cause peripheral vasoconstriction and increase the blood pressure. The most common one that I've seen being used is metaraminol, but you can also use phenylephrine as well. If a patient has dropped the blood pressure and the heart rate, then you can give an alpha and beta agonist, which most commonly that I've seen being used is ephedrine. Okay, so this is when the blood pressure and the heart rate have dropped. Sometimes the heart rate and the blood pressure increase, and what this usually means is that the patient is responding to the surgical stimulus. So what you can do is give the patient some analgesia, so some paracetamol or some morphine, and this usually does control the blood pressure. If it fails to control the blood pressure, you can start using drugs such as beta antagonists such as labetalol or esmolol, or an alpha-2 agonist such as clonidine, just to reduce the blood pressure. So now we're going to talk about the end of the operation and what we do. So when the surgeons say, okay, we're finishing up now, get the patient ready, one of the things we need to do is, if we've given the patient muscle relaxants, we want to get them to start breathing spontaneously again. So the drugs that we most commonly use are neostigmine and glycopyrrolate. Neostigmine is an acetylcholinesterase inhibitor. So what that's going to do is stop the breakdown of acetylcholine, increase its concentration within the nerve terminal, and it can displace the muscle relaxants. It also works on the cholinergic receptors, so it can cause increased acetylcholine within that area, causing a drop in the heart rate. So we like to give an anticholinergic such as glycopyrrolate or again atropine for that. Okay, so moving on post-op. So maybe about 10 minutes before the patient wakes up, we usually like to give them an antiemetic. So the most common antiemetics used post-op cyclizine and ondansetron. Cyclizine is an H2 antagonist, and ondansetron is a 5-HT3 receptor antagonist. So these are given prophylactically as the operation comes to an end, and we usually prescribe these drugs PRN as well. So if the patient's still feeling quite nauseous after they've woken up, then we can give them this. Dexamethasone is more commonly used pre-op, just before the patients come into theatre, and this is a steroid. No one really knows how it works, but it does have antiemetic properties. And finally, just a small bit on analgesia. Analgesia is his whole big topic for itself, and I will be giving a lecture on the management of acute and chronic pain from the anesthetic point of view. But just very briefly, we can give opiates pre-op, as I mentioned with the propofol. We often give fentanyl. We can give them intra-op, so again monitoring the blood pressure, the heart rate. If we think the patient's reacting to the painful stimulus, we can give them some morphine, some paracetamol. If there's no evidence of any reflux disease or renal disease, we can give them diclofenac as well. And post-op, we can prescribe the patient's analgesia PRN, just sort of oral or intravenous analgesia. We can set them up with a PCA, which is a patient-controlled analgesia, where there can be a background infusion of, for example, morphine or fentanyl, but they're also able to push a button to give themselves boluses. And another thing that we can do is set up an epidural. The epidural is usually placed pre-op and used intraoperatively, and post-op and carry on giving them usually fentanyl and bupivacaine. Thank you. Fine, so that completes my first lecture on the common drugs in anesthesia. So what we've kind of run through is the different drugs that I've personally seen being used very frequently in anesthesia, looking at the induction agents, the agents we'd give to paralyze the muscles if we want to set the patient up on the mechanical ventilator, the drugs we'd use to keep the patient asleep, how we'd cope with emergencies if there's changes in the blood pressure and the heart rate, and then post-op, how we'd reverse the muscle paralysis, and kind of management, analgesia and antiemetics post-op. So this is the first of my lectures. I'm going to be writing a few more lectures about anesthetics. So other things that I'm planning on covering is going through pain management, having a closer look at that, because we only went through it very briefly today. Going through the whole process of the anesthetic, so pre-anesthetic assessment, the kind of steps we take intraoperatively from the anesthetic point of view, in addition to the drugs that we've mentioned today, and post-op, how we care for the patients post-operatively. And I'd also going to write a lecture on the different equipment that we use in anaesthetics and the monitoring used there.
Fantastic. Thanks very much, Shireen.
Thank you.
We'll be back again with you soon, hopefully. Bye.